Good afternoon, everyone. We are so happy to see all of you join us this afternoon for this super exciting conversation that we're about to embark on, a conversation with the CDC's Dr. Mitchell Wolfe and our own Larner College of Medicine, Dr. Kelsey Gleason of our public health program. My name is Nicole Willie-Fenton. I work in our professional and continuing education department, and I'm very happy to guide you through this conversation today. Just a quick note, this is National Public Health Week. So we're so excited that today's theme, each day of National Public Health Week has a theme, and this day's theme is global health. So very appropriate that we're talking with Dr. Kelsey Gleason and Dr. Wolfe today. Before I introduce Dr. Gleason, I just want to mention this event is recorded. So you're welcome also to put questions in the chat box throughout the presentation. We left time in the event to get to your questions. So let's get started. I'd like to introduce Dr. Kelsey Gleason, an assistant professor with the UVM Larner College of Medicine Public Health Program. Originally, Dr. Gleason was on a path to medical school, but she became first interested in public health after taking an epidemiology course. I think that's always how it happens from what I hear as an undergrad student, where she realized she could move from just treating an individual to conceptualizing treating communities as her work in public health. That experience led her to pursue her master's and doctoral degree in public health, specifically in environmental health and environmental epidemiology. And true to our Global Health Day today, she's traveled around the world conducting field research in communities in the Amazon, Haiti, Kenya, Ethiopia. The list is quite extensive. And right now she is studying how environmental influences affect diarrheal diseases in the world's largest refugee camp in Cox's Bazar in Bangladesh. We're so happy to have you here, Kelsey. So Dr. Gleason, I'd like you to take it away, introduce Dr. Wolfe, and then we'll get started.
Thanks so much, Nicole, and welcome everyone. I'm so excited to be participating in this webinar as a part of National Public Health Week. And I'm really excited to be here today with Dr. Mitchell Wolfe, who is CDC's Chief Medical Officer and a graduate of our very own Larner College of Medicine. Dr. Wolfe first joined the CDC as an epidemic intelligence officer and then went on to serve as director of the CDC's Global AIDS program and the director of CDC's Thailand and Vietnam offices. After Southeast Asia, Dr. Wolfe came back to Washington to serve as the acting director of CDC's Washington office, which all led him to his current role as CDC's Chief Medical Officer. And I'm hoping we can hear a little bit more about what that title actually means. But in that role, he provides some support to CDC's director and interacts with key public health partners. He also works really closely with Congress, the White House, and other government and public health officials. So welcome, Dr. Wolfe. We're so excited to have you here today.
Thanks, very happy to be here.
I think we're going to start today with just a couple of questions from me, and then at the end of the webinar, we'll take questions from the group. So I want to know right off the bat, Dr. Wolfe, after attending medical school here at UVM, you decided to pursue your public health degree, your MPH. In keeping with the theme of National Public Health Week, could you tell us why you thought this was an important degree to have?
Sure, happy to. And I want to say again, I'm just happy to be here talking to everyone. I love being involved with UVM whenever I can. And looking forward to questions and answers after this. So, I think public health has a really wide scope, both technically, but also, local, state, national, and global. And the MPH gave me the opportunity to be exposed to a wide variety of topics and areas, and help me. And I think it's important for people to see sort of what you like doing, what you don't like doing, what you're good at, what you're not good at. I'll give you an example, which is I learned I am terrible at coding, and I took many SAS courses and static courses, and I cannot do it. So it's good to learn early what you're good at and what you can do, and what you don't like to do. And also, there's just a lot of foundational things that you learn in MPH because of the exposure to the various topics that you get. In addition, it really gave me an understanding of kind of the work environment for public health, what the opportunities were to do internships, to meet people and make contacts. And then also I would turn the question around a little bit and say, why, if you're going into public health, would you need an MD? And, I would say I use my MD every day with my knowledge and experience, not seeing patients clinically, of course, but it's extremely helpful. And I'd also say that I don't think an MD is necessary. I think that we need in public health a wide variety of expertise. In Ebola, we learned that we really need medical anthropologists, we need psychologists, we need social workers. CDC has a lot of veterinarians and dentists. Public health really encompasses a lot of aspects of human behavior and existence, and we need a variety.
Yeah, I think that that's one of the things that I have learned personally in my career and my career trajectory is kind of figuring out what fits and ultimately what sticks. And I think that that's important to not only acknowledge, but be okay with as we move throughout our careers, and be okay with that experimentation and with, finally admitting that this doesn't work, but this is a skill that I'm really good at. And like you said, your example with coding, I was laughing because I think so many people on the call right now are probably right there with you, and understanding that you don't need to be an expert coder in order to apply principles of epidemiology in your work. So throughout your career and your academic journey, did you always know that you wanted to end up in public health? Was it always your plan that you were going to do your MD and then your MPH, or was it kind of a trial by fire and a trial and error situation?
Yeah, I went to medical school in order to be I was going to be a family doctor in rural Northern California. That was kind of my vision. And I went to family practice residency in Sonoma County. And one day I was doing a mandatory rotation at the Sonoma County Health Department. I went to the TB, HIV, STD clinic, and I had no idea where I was or what they did. And luckily there was an attending there who was very interested in public health. And I said, like, what is this place? And they explained it to me. And that started me really exploring public health and what public health does and why. And within 2 weeks, I'd applied for a preventive medicine residency to actually change into public health. I knew that that's what I was going to do. So I ended up kind of changing my trajectory based on being exposed, to that clinic, but also that attending who was able at the right time to explain to me what I was seeing.
Yeah, I think that again speaks to the importance of getting out there and experiencing new types of opportunities, within the bounds of our current career trajectories, but also outside of them, and leaving our comfort zones a little bit in order to explore what we really are interested in. And that leads well into a next question that I have for you that you already answered a little bit, but I'm wondering how you think your MPH degree has shaped your understanding of medicine and your overall career trajectory.
Well, yeah, I did an MPH and a preventive medicine residency. The preventive medicine residency is really, you do an internship, then you get an MPH, and then you do a year with a local or state health department. And during my MPH, I just got exposed to things that I never thought about or never really understood that I needed to be exposed to or know, because with my medical background, things like public health financing, administration, data quality, things like that. It really helped put me on a path of like understanding the scope of public health and realizing that I didn't quite know what I was getting into until I was in it. And then, the kind of things that I wanted to learn more about. And just, in my preventive medicine residency, which you didn't really ask about, but it was part of my training. I was exposed, I was in Sonoma County Health Department for a year, and I was the acting county epidemiologist, and I worked in many different outbreaks on clusters of things like brain cancer, environmental health, like floods and Superfund sites, in grant writing. I wrote a grant for the first time, which we ended up not getting. And, just meeting the variety of people who work in public health. And, at a county level, county and global are very closely linked. I mean, at Sonoma County, I saw in 1 year, meningococcus, leptospirosis, malaria, Shigella, pertussis, a wide variety, measles of outbreaks that you see on the global level.
Right. Yeah. When I think of those diseases, I typically think of, Nicole mentioned my work in a refugee camp. So I typically think of those diseases in more low income, low resource settings. And so that's super interesting that you were seeing those, in California and kind of understood the public health relevance and the public health import of those diseases. So you mentioned at the beginning, again, that you're not great at coding. How were you then able to apply principles of epidemiology to your work without crunching data in front of a computer screen?
Right. Well, so at CDC, we had fantastic statisticians to help us actually do that work. But the epi work, is very conceptual and analytic, and you really need to know. I mean, for my work at CDC, and I think in a lot of public health, it's very important to know the fundamentals of epi, because whether or not you're actually, turning the knobs, that's a small part of what you're doing, but being able to know what questions you're asking and set it up correctly, and then be able to participate in the analytics, it's absolutely critical to have that background. So I use the MPH training and my principles of epidemiology and my blue book, my blue textbook all the time for the first few years, because I wanted to be an active, participant in the analyses that we were doing. And I did one analysis on my own using SPSS.
Nice work.
Which I don't know if that even still exists, but it's a point and click.
It
Right.
Totally still works, and I think we all use it all the time because of its ease of use and ultimately the utility of it. And you hit on a point that's really salient to my own life of just being able to have the background in all different kinds of public health practice and all these classes that we're taking when we are in medical school or doing our Masters of Public Health, where we know what we want to achieve afterwards. And we sometimes think, why am I taking this class in epidemiology? I do not want to be an epidemiologist. Or why am I taking this class in environmental health? And ultimately, having that foundational knowledge to be able to, when you're actually faced with a real world public health problem, view it from different angles is, I think, so necessary.
You never know where you're going to work, but when I worked at the county health department, I think I used, all of that, the administration, financing, environmental health, water, sanitation, all of that.
Yeah, totally. It's all related, and they don't exist within a silo. It has been my biggest lesson from public health. And that brings me to my next question, which is that one of the great things about public health is that it is so broad and diverse, but that can make picking one particular career path really challenging, especially when there are so many cool ones and exciting ones to choose from. So could you tell us a little bit about why you chose to focus on global health?
Sure. And, just a little bit about my experience there. I don't know if this is helpful for people, but, for me, sometime when there was so much available, it could be hard to choose something. And anything you choose is not going to have everything. And so nothing is perfect. Everything has, positives and negatives and good and bad. And one thing I really learned is even when you have a job that is not necessarily where you want to be, there's a lot that you can take out of that, because you can really learn what kind of environment you want to work in, where you do want to work, where you don't want to work, what kind of things you're good at. And so, I really recommend to people to make the most of a job that they don't necessarily want to be in, especially because you have to be doing a good job to get your next job. And so I had a couple that weren't quite good fits. And in looking back, those were extremely valuable for me to understand what's a good fit for me. For global health, I, like many people, I always had an interest in other cultures and traveling and feeling connected with the world, and traveling really opened up my eyes, and I wanted to contribute to make the world a better place and lift everybody up. And, I think a lot of people have that interest who get involved in global health. But, kind of a casual or an informal interest doesn't always translate to a work interest or a work ability. And so it's very important, I think, that you try it and see if that's really what you're good at. We've had many experiences of people who really like to work globally, but then when they're living overseas, it's just not a good match. And vice versa, people who never thought they did, and then they go overseas and they think that they realize that it's really what they're good at and what they want to do. And so what I did is when I entered CDC, it's a 2-year fellowship, this Epidemic Intelligence Service program, and I picked a program that would have some international experience, and they told me that it would, and I did a work in Egypt on lead poisoning from bread, and I worked on that project and realized that I just loved doing that kind of work and working with my Egyptian Ministry of Health counterparts and working with local Egyptians. And so then I took a domestic job in HIV with an eye towards going overseas. In the domestic HIV job, I learned a lot about doing studies, about running sites, and about analysis that I used for the future. So even though it wasn't global health, it really, and HIV intervention. And then when I went overseas, it was for HIV work, global HIV work, and it was directly applicable what I learned domestically for my overseas job. And it was really funny. The last thing I'd say is, I was in Zimbabwe looking at a job to be the surveillance lead for CDC. And I was there for a week. I loved Zimbabwe. I was just about to take the job. And I got a call from another part of CDC offering me a job to be the country director in Vietnam. And I just took it sight unseen, never having been to Vietnam. And so I think the lesson for me there was just being prepared in the environment to then, when you get the call, make the move if it seems right. So it was risky, but it ended up being the right move for us. I did ask my wife first, but that was it.
And if I recall correctly, you spent almost a decade over in Vietnam and Thailand. Is that right?
So I ended up, going to Vietnam. Vietnam was kind of a backwater, very low budget, small program with like 8 people. And that's why I took it. I wanted some experience working overseas. And then kind of unfortunately, it became a PEPFAR focus country. And we went from 8 people and a budget of $1.5 million. And by the time I left in 5 years, we had 55 people and $90 million and 2 offices in Ho Chi Minh City and Hanoi. And I got about, what I like to say is like dog years. I was there 5 years, but it was like 50 years of management experience in that time. And then I went to Thailand and I was the country director for 5 years there for CDC.
That's
so
great.
My son was 8 years old when we moved, and he graduated high school in Thailand.
Oh, wow. And so I just want to back you up a little bit, because I'm not sure everyone in our audience will know what PEPFAR means and the implications on that. Could you just talk a little bit about why the PEPFAR designation in Vietnam is important, and what kind of work was required on your part to do that?
Definitely do not let me get away with any acronyms. Sorry about that. That's So PEPFAR is the President's Emergency Plan for AIDS Relief. It was established by President Bush around 2003, 2004. It's the largest amount of money for one single disease ever. And although there's 15 focus countries, and it was primarily geared towards addressing the out of control HIV outbreak in Sub-Saharan Africa, it actually was global. It was around the world in maybe 40 countries, I think. And it's been hugely successful, benefiting very much from having a really clear outcomes, right? Number of people on antiretroviral therapy, number of people in care. And it's also very well organized as far as attaching annual planning and dollars to programs and outcomes.
Yeah, so that's really great work that you were able to do there, and such an important designation, as you mentioned, to be able to put the dollars there and then to see the achievable outcomes. So congratulations on that, by the way. That's really cool.
It was amazing. I mean, in Vietnam, when we got there were a few people on kind of imported antiretroviral therapy, maybe like less than 100 people, and who knows what they were taking. And we really, we were worked with the government to develop policies and guidelines to establish, I mean, there were many different things, but rigorous antiretroviral therapy for thousands and thousands of people. So it's felt great about that accomplishment.
Yeah, that's a huge accomplishment, and that leads really nicely into my next question, which I can't have you here and not ask you about COVID-19 and your work on it so far with the CDC. And I want to talk specifically about health disparities in COVID-19. The pandemic has shifted a lot of the ways that we see these health disparities, particularly in the global health context. So how do you see global health changing in the wake of COVID-19, or how do you see the CDC's involvement in global health changing following the pandemic?
Yeah, I mean, this is a really important topic. I think, I've been mainly involved in the global COVID response for CDC, and but I think globally and domestically, COVID has helped expose the weak public health infrastructure everywhere. I think that the work that we have done working with countries to build their capacity over the last 10 or 15 years has been remarkable, and we know a lot more than we would have 15 years ago about what was happening. And I think countries have been able to do a lot more than they would have been. So even though we have a pandemic, I do think we're in a better place than we were, but we've also seen how far we have to go. Part of it is equitable access to interventions, countermeasures like vaccine, right? I mean, there's been poor access for certain populations, and what we've said for many years, and now I think is policymakers understand and the public understands, is a threat anywhere is a threat everywhere. And that's not just global, but within a country. So you need to identify who is getting access. And I'm just using vaccines as an example. There's socioeconomic factors, there's race and ethnic factors, there's marginalized populations, there's age, and we have examples of all of those, in HIV in marginalized populations. Right now, there's just a huge outbreak in Hong Kong, and the elderly, which have lower vaccination rates, have a really high mortality rate. And so, and then of course, there's racial, ethnic access issues and hospitalization and mortality in the U.S. And so I think it's really brought that to light for a wide variety of people, not just public health people, but other policymakers. And I'm hoping that, this helps us with looking forward the capacity building that we have to do, globally.
Yeah, totally. And I mean, the one thing that we've learned from this pandemic is it's certainly not the great equalizer that everyone was currently, at the beginning was saying that it was. We're seeing disproportionate outcomes in certain groups and disproportionate outcomes across certain borders. And these borders are extremely porous, and the virus is, of course, impacting different communities in different ways. And through that, there's so many different players who are involved in trying to mitigate the impact of COVID-19. There's at the most basic community level, and then up to local, regional, national governments. But then you have players like the WHO and of course the CDC. Can you explain to me a little bit where the CDC fits into that response a little bit more, particularly in the global sphere?
Yeah, so CDC currently has offices in over 60 countries. We have about 2,000 people overseas. About 400 are Americans, and about 15 or 1,600 are locally employed staff, so host country nationals that work for us for maybe decades and are really the backbone of what we do because we come and go. But they are there, and we develop good relationships with ministries of health. but they developed these long-standing relationships for decades with ministries of health. Our focus is in a few areas. One is capacity building to help countries prevent, detect, and respond to disease threats. So core areas like disease surveillance, laboratory, health workforce, and emergency response and emergency operations centers. We also work on us responding, our CDC staff in countries and from headquarters. And when COVID started to spread around the world, our staff worked with Ministry of Health staff in those 60 countries immediately to help them with analyzing their data and developing policies and guidance and setting up their emergency response systems. We also do studies and research, on specific diseases and work on elimination of specific diseases. So we're very focused, for example, on polio elimination and the polio response. So we do a lot of that with WHO. I mean, WHO can do similar things, but they also work sometime on a more policy level, and sometimes they have relationships. When I got to Vietnam, they had the relationship with the Ministry of Health, who was nervous about a relationship with the US. And we actually partnered with them to develop our relationship with the Ministry of Health, which we don't kind of need them anymore. Now it's a more collaboration with WHO on various other kind of studies and policies, and we have our own relationship, but we needed them really for that relationship because they're a trusted partner around the world. So we have about 30 people detailed to WHO at Geneva and in regional and country offices. We just met with the WHO Director General and a delegation and our Secretary of Health 2 days ago and talked about potentially detailing more people. We talked with Dr. Tedros about, in general, they realize that there's so much work to do that even though some of the capacity building and policy work that we both do could overlap, there's so much to do that if we work together, then, we could probably have 5 CDCs and 5 WHOs and still there'd be more work to do. So we have a great relationship with them, and we partner in many areas. And I'm happy to talk about some of the detailed areas if people want to hear, but.
That's super interesting to hear. And I mean, the main takeaway that I just heard is that collaboration is key in order to create these effective public health interventions for any single disease that's out there, not only nationally, but on the international scale and in global health context as well. And I know too, at the CDC, and particularly in your role, the focus isn't necessarily just on infectious diseases, although there is a huge emphasis on that. And I know the CDC is doing a lot of work on the war in Ukraine right now. So I want to ask you about that a little bit, and that, Ukraine, the situation in Ukraine has resulted in a huge public health emergency. How do you, through your work at the CDC, go about prioritizing needs in such a complex and dynamic environment?
Sure, happy to talk about that a little. Before I do, just one thing you said, which is, well, actually, I'll get to it after. Let me start with the Ukraine. So when something like this happens, we all want to kind of respond quickly and do everything we can, and that's useful at the beginning. But it's really important to kind of sit back and say, what can we provide? What should we be providing? What's our comparative advantage? What are others doing? What are the gaps? So you've got this natural instinct to just do everything, and then you have to quickly kind of pull that back. So, when the invasion happened, we had planned on a high-level CDC delegation to the country of Georgia, not Atlanta, Georgia, but Tbilisi, Georgia, to look at our new regional office that we had set up there. And so it was actually good timing. We had some of our Ukrainian staff who were there, which it was a very tough time. That some of them had family members who were actively fighting in the war. And so our first order of business was protecting our CDC staff, our U.S. direct hire staff, but they had already left, but our Ukrainian staff. And so working on trying to figure out how best to support them and to protect them. Also, we have a very close relationship with the Ministry of Health, so staying in close contact with them, which we're, our Ukrainian country director talks with the Ministry of Health several times a day by WhatsApp and finding out what they really need. And then rostering our Russian speakers that would be able to provide assistance. And then looking to WHO on how we can work through them, because they are usually the ones who are able to respond very quickly and get the request to respond. And there are several mechanisms by which we can work with WHO to respond. There's a WHO hub in Poland, and there's a outbreak response network that we become part of. We sent a couple people to Geneva to help them with policy and assessments. And, one of the first requests that came out of Ukraine from the Ministry of Health was assistance with chemical and biologic, like fact sheets that they could disseminate in Ukrainian for clinicians on what to look for and how to respond. And so we took some of our website data, turned it into fact sheets, translated into Ukrainian, and disseminated that with the Ministry of Health. And then a lot of work with WHO, rapid assessment tools and other kinds of assessments and COVID mitigation. And then working with WHO, the regional office in Euro, for helping with immunization. We're worried about outbreaks of things like measles or polio, and working with WHO and neighboring countries on their surveillance systems and outbreak response in preparation for the potential for these outbreaks. So again, I think it's wanting to do everything and then realizing what should we be doing and what is our comparative advantage, and really trying to focus there.
Yeah, and I think that's such amazing and important work. So again, thank you for taking the time to talk to us out of your busy schedule when you're doing a lot of other really important things. And I think that also speaks to the importance of collaboration in public health, is being able to work with these other organizations. And again, at the beginning, when we were talking about just personal careers, figuring out what you're good at, I think that translates well too to an organizational level, and figuring out what organizations are good at and delegating to other organizations as well. So thank you for sharing that. And I want now to hopefully switch over to some questions from the group, rather than, I don't want to take up all your time. I want to give the crowd an opportunity to ask some questions.
Yeah, I'm I'm ready.
Great. I was just waiting for them to come in, but it looks like we have a really good one to kick you off. So, according to a study published in Clinical Infectious Diseases, investigators documented a lower vaccine effectiveness in those who had flu vaccine over the previous 5 years. Additionally, according to data published by the CDC between 2010 and 2020, the effectiveness of seasonal flu vaccine has decreased from 60% to about 40%, with much of the population receiving 2 to 3 doses of the COVID-19 vaccine within the last year. Could we see a resurgence of COVID within the next few years due to the vaccine boosters losing their effectiveness for those who have previously been vaccinated?
Yeah, that's a great question. So, we're all now learning real time about how to deal with this, with coronavirus and COVID, and don't know what's going to happen in the long term. We can predict. One thing that I know is that our predictions are not always right, or maybe never right with COVID. But I think there's some general things that we know. One is, I think COVID's going to be with us for a long time. And I think that we learn that we can develop a vaccine very quickly that's pretty effective. Looking back, if we thought that if we had a vaccine that was 50% effective, we'd be very happy. And it's much more than 50% effective. So we're learning a lot about whole cell vaccine and homologous and heterologous, series, and when you need boosters. And it's just, I don't know what the answer is for what's best, but I think that we have good protection, that if we can get most of the population vaccinated, that will help with both herd immunity and with individual protection. It is totally possible that we will have other variants that come out. Right now, the vaccines are probably pretty good about the variants. I hope that that stays the case, but I think we're developing technology at the same time that we're developing our surveillance systems. And so it's really just going to take a, concerted effort to stay on top of this and keep evaluating what's happening, because it's hard to predict what's going to happen. And I'd be happy to hear what anyone else on the call thinks too about that and what predictions you might make.
Yeah, it's so tricky. I mean, if we were able to predict what would happen, I don't think we'd be in this position, And so even the best guesses are really guesses at this point, and well educated, but really variable. And so thank you for sharing that, and thanks for the great question from the crowd. We have another question from Laura, going back to your work in Vietnam. Did you, in your previous work, do any work with water quality and the relationship to public or global health when you were in Vietnam or at any point in your career?
Yeah, I personally haven't, although it's an incredibly important topic. One thing I'd say is, when I was working in Vietnam, I was there for HIV, but I kept a list of people from CDC who came to do projects and talk to them all. And we had 27 different projects, from Agent Orange to road safety, smoking, rubella, neonatal vaccinations, rubella vaccinations, neonatal tetanus, a wide variety of things. So even though we may have been funded primarily and there to do one thing, we were doing a wide variety of activities that I think had a lot of impact. I personally have not worked on water quality. Sorry.
No apologies necessary. It seems, from what I've heard, that's maybe the one area of public health that you haven't worked on so far. So, I mean, there's still time. We have another great question from Ella. As a first-year undergrad interested in public health and possibly in an MD, MPH, do you have any advice for someone following this path? And is there anything you wish you knew at Ella's point in her career that you know now?
I love that question, so thank you. That was not a planted question. So like I went to undergraduate, I was an English major. I thought I was going to be an English professor. My last 2 years, I was in a rock and roll band, and then I was in that band for 3 or 4 years after, trying to make it as a rock and roll musician and tutoring, English and math on the side. So there's a few things. One, I think the most important thing is that I think people should study anything that they're interested in. What I feel like the people who are most successful in public health are good communicators and good at analyzing problems and trying to fix them and working as a team. You can do that with any undergraduate major, I think. And people often ask, what kind of skills should you focus on? And my answer there is, I don't know, but you probably know. Whatever you're not good at is what you should focus on. And whatever you're avoiding doing is what you should focus on. So I know, looking back, I avoided public speaking because I hated it and it made me very nervous. And I remember giving my first talk at CROI, which is a large antiretroviral, conference, and my knees were shaking. And when I became country director in Vietnam, I was not used to public speaking. And so I paid the price, and it was hard. And I highly recommend that you look at whatever you're avoiding and work on that. And that's the thing that I think, everyone needs to focus on. You can be in any field and go into public health and do well.
That's great advice. Thank you. We have another great question from the crowd that kind of builds nicely upon one of the questions that I asked you earlier about COVID-19 and health equity. So specifically, how do you and your team or the CDC overcome the political nature of COVID-19, both here and abroad?
So, I mean, it's a great question. I'm not sure anyone has overcome it. One of the things that maybe at least surprised me, is the political overlay of the outbreak globally. You know, almost everywhere. I think one thing we've learned is that where we do best is where we're aligned from the national to the local level. Countries that have done the best, I think, are well aligned. Shouldn't be too surprising that there's a political overlay because of all the ramifications. You know, when Ebola happened in West Africa, we really tried to encourage the countries not to close their borders because it affects trade, it affects the economy, it affects the economy, and also it affects the ability to actually go in and assist the countries. So, afterwards, I remember going to a African economic conference and talking about that. Yet when coronavirus happened, we all closed our borders, and in the end, maybe there's some effectiveness of that. And so we're really, I think, need to look back and assess how we address, how we respond to outbreaks. There may be some border closings that are very useful, and it may be that it's for a certain time, and we have to assess what the economic ramifications are. So, it's typical in public health that it's not just people in public health that you need to deal with to kind of solve problems. It's everybody.
Yeah, and
sorry, I don't have an exact answer for that, but it's something that requires, everybody to try to solve.
Yeah, and I think that's fair. Again, if we knew how to solve that, if we knew how to solve the politics of anything, we would be in a much better position, but particularly around COVID-19. But it's great to hear that the CDC and a lot of other groups are actively working on that and learning from past mistakes, not just with COVID, but with other outbreaks as well. And we have a great question from Patrick about global health, in that global health appears to be a space full of actors that have vastly different motivations and responsibilities. How does your role as a representative of the US CDC differ from the role of NGOs or global health organizations that are not associated with the national government?
Yeah, I think it's important to realize that when you work for CDC, you definitely work for the US government, and you represent the US government, and everything you say represents the US government. And, some people, we get a lot of interns and fellows at CDC, and thing I tell everyone is this is a great test to see if you want to work for the US government. You have an immense amount of impact in the decisions that you can make. I gave PEPFAR as an example, but your decisions have huge impact, yet you're not free to kind of do anything you want, and maybe not as free as you might be in NGOs. People go back and forth all the time, and people often come back from NGOs and say, well, I want to come back to the US government because I want to have that impact. So I think it's good to get a wide variety of experience to understand kind of what you want to do and what you want your levers to be, and how close you want to be to people or to funding decisions or to policy decisions.
And how closely does the CDC work with groups like NGOs, or do they?
We do. In countries, the primary funder of NGOs is USAID.
Yeah.
But like when I was in Vietnam, we worked with several NGOs to work on things like antiretroviral therapy training for clinicians, or addressing certain groups like intravenous drug users, or starting methadone for drug users and addiction treatment, and then special programs with children, and then NGO that worked in road safety, developing affordable helmets for for the population. And so we tend to work with them on more of a technical assistance and policy collaboration level than necessarily funding. USAID tends to fund NGOs more, but we work with a lot of non-governmental organizations. And then depending on your definition, we work with other donors quite a bit, like the Bill and Melinda Gates Foundation, for example, or the Global Fund, where we try to coordinate with them so we're not duplicating activities and we're synergistic and not fighting against each other.
Yeah, super interesting. We have a great question from Megan that kind of brings us back to the original question from the audience. Adding to that first question about vaccines, have you seen a difference in the effectiveness of vaccines as related to comorbidities, specifically things like diabetes or obesity?
Well, yeah, I mean, some comorbidities are definitely, lead to higher hospitalization and mortality. Vaccination definitely protects, but I think that with some of these comorbidities, you still have a higher hospitalization and mortality. We are constantly looking at vaccine effectiveness and different regimens in different groups. And I think we have a lot more to learn about that, about what works best.
Yeah, definitely. And I think, as the goalposts are constantly shifting and we're constantly learning from a public health perspective. And you and I were talking earlier about how, the people who work at the CDC and yourself and, us in academia, we're all trying our best to figure things out. But at the end of the day, we're still human too. And we're, kind of looking for answers along the way.
We were talking about that earlier as individuals figuring out, what do I do every day? Because my mom is coming to visit next week and she's just finishing chemotherapy and I don't want to get her infected. And so, what do I do about masking when I go, different places?
Yeah, totally.
We're all in the same boat.
We're all in the same boat. It's true. I want to move now to a question from Elizabeth. She's interested in animal health and its overlap with human health and am considering pursuing a veterinary degree. While that isn't your primary focus, could you please explain the role of veterinarians in your work with global health? I know you mentioned the importance of zoonosis work earlier.
I'm so glad you mentioned that because I always say that the vets are the smartest people at CDC. I've worked with a lot of veterinarians and they are incredible, incredibly important epidemiologists. The human-animal interface is so important and it's an area that every country talks about as wanting to increase. There's a huge room for, more and more people who work on animals and veterinarians for that animal-human interface and animal diseases. Origins of COVID is a perfect example, but there's a lot more. And especially with climate change and things like, vector-borne diseases. And so I would just say, please go into animal health and be a veterinarian, and please go into public health because we need you.
Yeah, I couldn't agree more. And having known veterinarians who are working in the public health realm, I can also echo what important work they do and what the work that they do is often not super on the face of public health, and until we see things like a COVID pandemic. But it's super interesting to hear that that's your perspective as well. And thanks for the great question, Elizabeth. And now we're going to turn to another question from Patrick. You made mention of the similarity between county level public health and global health. Could you expand on these similarities, and have you found people cross over between these spaces?
Yeah, I think a lot of people who work in global health would say that there is a real similarity or analogous work between local public health and global health. You're very close to people. You're working with governments who are implementing programs, right there. You get to go see those programs and analyze those programs and provide recommendations. You're closer to people who benefit from who are recipients of those programs. And so everybody I know who's worked in local or state health department has said at local or state public health who had then worked in global health said that the work that they did helped them greatly. And we get a lot of people who were in state health departments or local health departments that are then, maybe volunteer or work with a group doing global health and doing clinical work and then transition to CDC for the more public health policy work. And they are, they're extremely valuable to our organization. So it's just really, really clear that there's the connection. And it's also a great source of staff for us.
Yeah, I would echo that too. I think in my career in global health, the main lesson that I have learned is the wealth of knowledge that communities have. And I think that it doesn't matter if it's a global health community or a local county level community. I think, utilizing and leveraging the strengths of the community and understanding the needs at the community level is really important, no matter if you choose to focus your career globally or locally. We have another question now from Nadine. She says she's at a mid-level point in my career outside of public health and am looking to transition into the public health field. I just got my MPH, congrats Nadine, and have an internship with the public health law program with the CDC. Amazing. Do you have any advice?
Yeah, I talk to a lot of people who are doing this, and it's hard. It's hard to do a mid-career switch. For CDC specifically, by far, I tell everybody the best way in is through an internship or a fellowship. Many people, the act of applying to the federal government is extremely difficult, and it's extremely difficult to get in. And there's a lot of hurdles, kind of operational and legal, to get in from the outside. By far, the best way is in through an internship or fellowship, even if it means a salary cut for a while. So that would be my number one recommendation of the way to get in. And then the other is to kind of be flexible about what you do, because probably there's a wider variety of things that you may be exposed to that you'll end up liking, like we talked about kind of earlier. And so I'd be kind of open to a wide variety of things in that internship or fellowship.
That's great advice. Thank you. And we have a question now from Matt, who is a registered nurse. Do you work with registered nurses at the CDC? Because I'm interested in pursuing my MPH soon and an internship eventually with the CDC, but I haven't found any internships open for RNs. Do you have any recommendations on next steps?
So I definitely worked with a bunch of nurses at CDC, so it's a possibility, and they have a wide variety of kind of epidemiology, public health, prevention types of jobs. So definitely there's the opportunity. The way in, like I said, internships and fellowships. Other than the Epidemic Intelligence Service program, I'm not 100% sure which what RNs are eligible for. And afterwards, if someone could send me an email, I'll be happy to find out, with the person who heads that at CDC.
Thank you. We'll definitely take you up on that. And our, unfortunately, last question of the day: has the rise of multi-drug resistance had any particular effects on global health disparities? And if so, how are these addressed?
That's a great question. I don't know the answer. I suspect it has to have in the socioeconomic, right? Because multi-drug resistance is such a problem, and it's such a problem now in the primary health care as well as tertiary medical care. So I would imagine that in all the areas that racial, ethnic, socioeconomic, age disparities, I think that it's probably analogous in multi-drug resistance. But specifically, I don't have great examples. Others on this call may, but
it's a tricky question. And, we just want to thank you so much, Dr. Wolfe, for taking the time today and for giving us the opportunity to pick your brain on all things public health, global health, and everything in between. And we are so grateful that you essentially started your career with us here at the Larner College of Medicine, getting your MD, and then moved on to do such amazing things. And we know that, like I said, you've got many other important things to do. So thank you so much for sharing your thoughts and expertise with us today. We're extremely grateful.
Happy to do it. Happy to talk to UVM anytime. I really appreciate people being on, and especially all the questions. Those are great questions.
Yeah, we very much appreciate the questions from the crowd. They were great and not too many stumpers, so we appreciate that.
Good that there were a few. Keep it honest.
A perfect amount, I'd say. So with that, thank you so much, Dr. Wolfe, and thank you so much to everyone tuning in. We really appreciate you all joining us today, and have a great evening.